get to him. They said, no, let's see what's going on. I'm like, well, if he's in V-fib, I need to get to him. And look in the room, and he's sitting there. I'm like, come with me before they kill you. Yeah. But
hey, welcome back to On Scene Podcast. This is George. We've got Matt.
Hey, how's it going?
How was LA?
It was great.
Okay, it's enough. I don't want to hear any more about it. And we've got Jon back, the legend, Jon Cresong.
I was looking for him.
Did you find him? Did you find him?
It's good to be here.
And we've got 2-year medic students in the studio.
Yeah.
Hanging out.
Y'all
just sit back here and keep your mouth shut. Stay quiet. Study something.
Just pretend you're being asked a question.
Crickets. I need a cricket button. I don't have one.
Uh-oh.
You got too many buttons as it is.
Sad. Nope. I've got nothing for crickets. That's awful.
Ain't nobody got time for that.
Okay. I substituted. Let's see. We'll go ahead and get into it. This one's probably about 20 minutes, 20, 30 minutes, something like that. Mm-hmm. Not a whole lot of blah, blah to do beforehand. I can't think of anything other than we've got a EMT class finishing up this week and a new one starting next week.
Yep, September 18th.
And the guy we had on 2 episodes ago passed his EMT-M course and passed his state exam, is now an EMT minor.
Congratulations.
Yes.
Yeah.
Did an
really
excellent job with him. You did?
Well, I give him the credit. He put in a lot of study time right before the test. As do most people, right before the test. Let's cram then.
Noticing a pattern here.
Yeah. We got a couple new camera angles. You can see me and Matt real good, and then Jon over there on his own little camera angle. Right here, Jon.
I have to have my own camera.
Yeah, look at that. Yeah, it's because you're special.
That's what it is.
All right. I have no segue into this, so we're just going to do it.
Yeah.
Right? Okay.
So
well, I'm going to push the button. I mean, I'm still going to push the button. I'm just thinking.
It's got to push the button.
The only segue I've got would be, everybody clear?
Yeah.
I'm clear. You're
Stand
clear.
back.
We're all clear.
I done forgot what we call this, so when the music
Cardiac
plays,
arrest.
you can announce it. All right.
Okay, so today we're going to be talking about cardiac arrest.
Shock or no shock?
Shock, no shock.
I'm shocked.
Thought we would talk about then versus now.
Little shock, big shock,
Yeah.
major shock, perfect shock.
Jon can kind of fill us in on how things used to be done. And we'll talk a little bit about
how things used to be done. Jumper cables and a
a lightning rod.
cardiac thump.
And then, how things have changed and progressed over the years and versus, what we're doing today.
Yeah, it was much different when they had flint and steel.
Yes.
Yeah. Yeah. That's what they had when Jon started.
Yeah, that's what. But right then, we just
The chisel and tablet.
they just stopped using flint when I started.
Yeah.
Build your own hydro dam. Get power from.
No, I mean it's changed so much, and even in our treatment actually has gotten simpler,
But better.
Depends on how you look at it.
I
Maybe.
mean, I guess on one case you'd say yes, but now we got different ideology and the way it was, because like when I started out, because we're talking a little bit about whether we should talk about working these patients on scene versus loading this patient up and working the cardiac arrest while you're on the way to the hospital.
Yeah, that's been like a big topic of conversation over the past few years, especially in the last 5 years. There's been a lot more data coming out, and they've been looking at, which is better. Should we work it on scene, or should we load and go? How about tell me a little bit about what it was like when you first started. How did things go then?
From my day, and I think a lot of us around that time, when we started, it's been hard for me to transition because you get in a certain mindset, and we was taught you load and go. Motion is medicine. Get down the road. Mm-hmm. Lights and sirens, you can go 10 miles over the speed limit and ain't got to worry about it, But nowadays, everything has changed on that side of things too. But you got real proficient at doing CPR with one hand on the bar and one hand on the patient, which is probably why my hand don't work now. But no, we done those things on the way down the road, but our skill set, I think, was better because of the conditions we had to do it in. I think that's, I'll say that to my benefit, was the situations that I found myself in, I had to,
kind of adapt and overcome.
Exactly. So, intubating, going down a holler like that, as opposed to doing it in a house where you ain't got to. Well, this is going to be 100% better,
Well, yeah.
And so is your IVs, and so but yeah, it was just load and go. We get them going, and you work it to the hospital, and then you collapse afterwards.
And I bet them Model A's didn't ride very well.
No, it's really tough.
The suspension.
It was that one horse that was so slow, Yeah, exactly.
But to be fair, some people's skill sets or skill levels were a lot better than others.
It's true.
What you may be able to do on the way was not what someone else may be able to do on the way, as far as like quality of compressions and everything like that, which I think is what's drove a lot of these changes.
It just it just makes perfect sense. I can't argue that. It's like I was telling the class, I was a big proponent of let's load and go, load and go, load and go.
Mm-hmm.
Intubation's the best thing in the world, and you get a good IV. You get a good IV, and but I can't argue with some of the new methods and some of the new tools that we have at our disposal.
Right.
It just makes sense that it's better for the patient, so we need to go to that. So.
Well, and even with like intubation and airway, for so many years it was always, I got to get that airway, ABCs, airway first. But new data and recent studies have shown that it's not even first anymore. We need compressions and ventilations, yes, but you don't have to get that ET tube. And depending on where you're working, like some places in Virginia, iGel during the entire code.
Yep.
You drop the iGel first. It's a blind insertion. It's quick. It's easy. It's secure. You work at 20 minutes on scene. You get ROSC, then you intubate, and you stabilize the patient and get them ready for transport. And
right. I can't argue that. The clinical data and the studies are there that prove. So,
yeah, but
for most people, doing an iGel is faster. It just is.
But that comes to your skill set.
Going to that IO first thing out the bat,
Yeah.
That's good medicine. I can't argue that.
Well, even that wasn't a thing until recent years, because for the longest time we had to attempt an IV 3 times before we went to the IO.
Right.
So, and now it's during cardiac arrest, that can be the first thing we go to.
Right. That's just it. Plus, we also had to crank that down by hand.
Yeah.
We used to have to do those, and now you just.
True. Which I did get to the point where I could put a manual IO in quicker, and you can get that gun out.
I'll guarantee it.
Yeah.
Guarantee it. Yeah. No, it's a lot more simple.
Yeah. But so there's been like a big shift in recent years in the mindset, and getting out of that mindset of, well, this is how we've always done it, to, well, now we got data that says this is a little bit better, so and a lot of people have been resistant to that, but a lot of people, now that they've seen it and seen it proven in the field, are like, you know what, maybe this does work. And hopefully, which that's kind of part of our mission here, is to get people the best information, the most up-to-date information, and kind of get people out of that mindset. Well, that's just, we do it that way because that's always how we've always done it, and we can't think like that anymore.
No, that's that's part of the problem. Was, like, I guess you'd say, for my generation, as opposed to today. So, like, the load and go, that was just in our minds, so you couldn't get away from that, and it was hard for me to break that. But also, I had a method of running a code that is so. I tell them so many times, I said, you all can't gripe with me about learning how to run a code. I said, because when we done it, we had a little mnemonic that we used. It was shock, shock, shock. Everybody shock, little shock, big shock, major shock, perfect shock. And so we went through. You had to go through. you done epinephrine, and we had no epinephrine, 1 milligram of epinephrine every 3 to 5 minutes for the duration of the code. Then you shock. Then you do lidocaine, 1.5 milligrams per kilogram to a max of 3 milligrams per kilogram, and then you shock. And then you go through procanamide, you go through mag sulfate, you go through beryllium, you go through procanamide. I mean, so, yeah, there were so many more drugs we had to know and so many more doses. Now it's epi.
Yeah.
Ain't
Epi.
nobody got time for that.
That's exactly right. So, and then it's like,
And then
consider amiodarone or lidocaine. So,
I was just getting ready to say, and then in recent years, there's been the whole amiodarone versus lidocaine debate, and we could probably do a whole episode on just that
Absolutely.
subject right there too. And I think the consensus is now one's about as good as the other. I don't think there's one preferred. There for a while, it was amio. You had to do amio.
the survivability, I think, was what made the switch back, more or less. But they never went away from lidocaine, so.
True. Lidocaine's always been there, but some of the older drugs that left are starting to come back as well.
Oh, yeah. It's like, I think dopamine, they've taken it away now.
Yeah.
And so.
Which, it was very prone to dysrhythmias too, like especially with like symptomatic bradycardia and things like that and cardiogenic shock. They started going away from that and more towards the Levophed or norepinephrine.
And see, that's funny too, because even though we did dopamine, they always said dopamine, the kidney killer, and there was
Right.
always the saying, "Leave them dead, Levophed." So
Right. And now we've come full circle. We're back to Levophed.
yeah. And so it's amazing. And then of course we're talking about that they want us because the studies are out there, and I guess the results are in favor of working a cardiac arrest on scene. Obviously there are times when you can't due to maybe the environment or,
Right.
the location of the patient. But if you're like at a home and like I said, long time to get my mind wrapped around that, but I can't argue that doing CPR not moving is better than doing CPR moving.
Yeah. Well, even
More
in some cases with the mechanical CPR devices, that did make it better as far as moving the patient and transporting the patient. But even with staying on scene with a mechanical device, your chance of getting them back raises exponentially.
And I love the mechanical devices. They're definitely a step forward. But on that, I have seen so many of those applied incorrectly.
Mm-hmm.
And then you got patients that don't fit the demographic. I mean, our population, I'd say a greater number doesn't fit a Lucas device
Right.
than does. So and so, I mean, yes, it's consistent, and yes, it's it's computer driven, I guess you'd say, on some level. But anyway, the thing of it is in medicine, I still think there's a lot to be said about our clinicians. You know what I mean? Our EMTs, paramedics, nurses, doctors. It's just that hands-on is always going to be a better.
And that's what with this last couple protocol rollouts we had last year and this year, our new state medical director, he's really pushing EMS in the right direction, because
Absolutely.
it's putting more confidence in paramedics and EMTs as clinicians. We're actually able to operate within the scope of our practice without, with less restrictions.
That is true, and he's because he listens.
Exactly.
I mean,
yeah.
I've never met anybody like him, so it's
And George, you can jump in anytime.
yeah.
You know what? Actually, I've been thoroughly enjoying not having to direct and lead and just kind of kick back like us EMTs and EMRs and drivers do when the paramedics just get going. Okay, hey, I'm here if you need me. Let me know if I can go get you something. I know where the flushes are. Coffee. I'm just actually, I was going to mute you guys a minute ago and talk to just the EMTs and below. And let y'all just continue, but I decided not to because it'd be kind of rude. Although it would have been entertaining. But no, I don't have anything to add because you guys are right.
Well,
I had to,
in your
Okay.
opinion, I do want to kind of touch on some of the as from an EMT standpoint, because you got the paramedic standpoint over here, but from an EMT side, what are some of the risks versus benefits of working these patients on scene now that things have changed so much?
Well, I've broken a nail a time or two.
I don't think you can get comp for that.
Yeah, no, they won't. No, well, what you're saying is exactly correct. I agree with the automated, like the Lucas device and things like that, you're going to get more proper chest recoil and proper depth and proper rate. But I also get that there's no substitution for that hands-on. You get that compassion aspect.
Right.
And as far as seeing differences go, I didn't work in the field that long to be able to speculate, what works and what don't. Actually, when I was working, we had one device at the company that I was working for, and nobody was allowed to use it.
Right.
Because we just got it, and they're like, hey, look at this. Nobody knows how to operate it. And so I've never actually used one in the field. We've always done full-on hands-on.
Well, they're so great that they're even doing studies now because you have what's the word I'm looking for?
Machines are taking our jobs.
Conscious.
I thought it was funny.
CPR induced consciousness, where the Lucas is doing such a good job, and it's circulating the blood so well that patients are coming to, and
I've seen it happen though
in
real life without a Lucas.
Yeah.
Yeah, it was amazing and totally.
You must have had an amazing EMT with you.
Well, let me tell you something. No, I was backing up another medic.
Oh, okay.
So, but anyway,
even better.
And it was one of our guys. So, but no. So on that side of things, I mean, I open up the back doors to help this other medic out, and he's doing compressions. Exactly. And so he's doing compressions, and every compression that he does, the patient's going, ouch, oh. And I'm like, oh, hold on a minute. I'm like, we don't do compressions on people that are talking. And and he says, no, man, watch this. He said, John, you got to see this. And he said, ow. He stopped, and you see it on the monitor. I went,
do it again.
Same thing happened at the hospital, so the doctor's like,
goodness.
stop. And I mean, you want to talk about a poor perfusion heart? As long as we did compressions, he was,
wow.
yeah, he was alert.
That's amazing. Jokingly in a lot of my classes, I always tell even EMTs and paramedics both always have this running joke that general rule of thumb, we stop after the second ow.
Yeah,
but that wouldn't apply in that case.
Like I said, it was crazy.
But yeah, wow.
Yeah, so that was an amazing situation. I hadn't been a medic long when I was just like, because I have responded to other we'll say
responders,
card holders who. Actually, the patient will be fighting them, and you're like, what are you doing? They said, I'm trying to save his life. And I'm like, stop.
You won't let me do CPR.
He's like, yeah.
How about you?
And been to facilities, and they say, hey, the patient's in VFib. So I'm like, well, let me get to him. They said, no, let's tell you what's going on. I'm like, well, if he's in VFib, I need to get to him. And look in the room, and he's sitting there. I'm like, come with me before they kill you. Yeah. But now, when we talk about doing these things on scene, I can think of situations. I can think of two personally. One was magnificent. I was working with the fire department, and we was on scene, and the family was in the house, and we worked him. I mean, done everything that could be done was done, but we just got nothing back, so we called it on scene. The family was actually really appreciative of our efforts, and they knew that we did everything, because they seen it done.
Right.
And we actually even had a prayer with the family there, and it gave them closure, and they talked about how well that went. But I've also was doing CPR one time, not far from here, when I was an EMT and working this area here. I was doing CPR, and this lady obviously had a heart attack while she was in the bathtub. And so we got her out of the bathtub, and we was doing CPR, and I was doing CPR with my partner, which is strange because this is sort of like a George thing. So the medic went back to get the monitor, and I'm in the house in the hallway on this patient, and just got out of the bathtub. So, and I'm doing compressions, and a family member came in the back door and didn't know that the patient had coded and just seen me on top of them, and they thought something else was going on.
Oh, no.
And I woke up being taken care of by another
heard this
EMT.
story. Yeah.
So I woke up because I guess I got knocked out. I guess I got hit behind the head because they didn't understand. They didn't know we was in there doing CPR, and they thought something else was going on. And so it could be dangerous that way. So
yeah. Well, I mean, I was thinking about it earlier.
Yes, there it was.
I'm sorry, I'm late. I'm sleepy.
Yeah.
I'm pretty tired today.
Oh, it's that kind of resuscitation. Okay. So but it was
there are
horrible.
a lot of benefits, but there's also a lot of risk too. I myself have been on scene working cardiac arrest. These situations are always very highly emotional because this is someone's their father, their brother, their husband laying there, that we're trying to take care of. So you'll have family that's very upset. It's a very rough time for them. It's also, if anybody's ever done CPR, seen CPR done, it is brutal.
It's brutal.
Like if you're doing it correctly, it's traumatizing for the family to see.
And if you put a tube,
yeah,
I mean it's
so you got the trauma aspect of it, and then I was working that cardiac arrest, and somebody was not very happy, and I could hear them arguing in the next room, and we're in the bedroom, got this guy out, down on the floor. We presume he had a heart attack, and they had seen him. He'd been sitting up eating breakfast, and shortly after breakfast, he went unresponsive. That's when they called us. So we pull him down into the floor, and we're doing CPR, and somebody, cousin, brother, or somebody had come in, and they're arguing with the mother in the next room, and I'm hearing all this, and I'm like, I'm getting a little bit nervous, and we're just doing our thing, because that was right when they started pushing, 20 to stay alive, or I think that's what they called it, or where they wanted us to start staying on scene for 20 minutes of cardiac arrest, several years ago, but it was when they first started that initiative, and not everybody was doing it, but it was kind of a new thing, so I was trying, to be a good paramedic, and so I'm working this, and I'm listening to that in the background, and all of a sudden I start seeing this guy walking back and forth in front of the door, like where we're working, like he's looking at us, and he'd glance in, and he kept pacing, and I could see him with his hands down beside him, and he was just clenching those fists, and I'm like, I think we probably should load this guy up and take him on in, because that we were so close to not being a very safe scene. So that's when I think about the same time a second crew had showed up to back us up. So when the second crew got there, first thing I said was, we would need to go ahead and load him up and take him to the hospital and see if there's anything else we can do along the way, and see if the doctors can find anything, do anything, and just trying to smooth it over with the family. And we got him on the backboard and in the truck, which I always personally, like you, always preferred loading and going, because that's my safe space. That's my office. That's where I do my work, is in the back of the truck. But of all the ones I've worked on the scene, that's the only one that really made me nervous.
I see us going back. I really do. I'll see us going back to moving the hospital, and the reason I say that is I was just sitting here thinking about recent studies and everything, and I don't know what it's called, so I'll not act like that I do, but there's a condition where they're saying that people have, is it called pseudo PEA?
Mm-hmm.
Yeah. And so if you had a PEA on the monitor, and for those who don't know, we're talking about pulseless electrical activity, which means we have a rhythm on the monitor, but there's no pulse to go with it. But if you have that going on, then, transporting that patient, that's the only way you're ever going to.
So in pseudo PEA, you actually have an organized rhythm on the monitor. So you may have them in sinus rhythm, but not a palpable pulse. So for years, we've always called that PEA because it's pulseless electrical activity, right? But with pseudo PEA, what they're finding out is they actually have cardiac movement. They have cardiac contractility. It's just not pumping hard enough to palpate a pulse. So that's why they started calling it pseudo PEA, because you still couldn't find it. You couldn't feel the pulse, but there was cardiac movement, right? So the heart muscle was actually contracting and pushing, just wasn't pushing hard enough. And what I actually see maybe happening before we go back to transport is point-of-care ultrasound.
I was going to say,
it's
coming soon.
Yeah.
Star Academy. So
Point-of-care ultrasound.
It's really starting to
Yes.
become more affordable, and there's really they're doing a lot of studies right now that have shown some positive results of its benefits in the field, and one of them is during cardiac arrest and determining PEA versus pseudo PEA, and because as long as you get that cardiac activity, as long as there's something going on in that heart, studies are saying we probably should be doing everything we can to try to get them back. That's going to be drugs, airway, CPR, the whole 9 yards. So I actually see now whether or not it happens here in this area, I don't know, but I know there's a big push for it. I would love to see ultrasound on the truck. I think there is a lot of good applications. There are also some arguments against it, so I don't know. We'll kind of see how that debate plays out in the next couple of years too.
it's one of those few things, though, that I see that I can see the benefits. And really, other than maybe the cost, would be the biggest thing against it. But we've come so far from when I started, and you done a 3-lead, and now we do 12 leads.
Right.
And that's the standard. That's
if you think about the cost, if as far as that aspect, if there's a way to sell it to the local squads, think about the cardiac monitors, how far they've come once the squads realize their benefits and start putting them on every truck. And now, more recently, look at the mechanical CPR devices, the Lucas. The Lucas itself is, I think, a used one just a couple of years ago was like $27,000-$30,000, right? That's a lot of money. But now that price is reduced. I'm not sure what it is right now, but I know the prices have come down, and we're starting to see them on a lot of trucks in West Virginia.
I know Wyoming County just approved to give all the fire departments Lucas devices in the county. So they're moving that way too. So we're just increasing our patient care.
So if you compare that cost to a point-of-care ultrasound is a fraction of the cost. You can get where you pay $30,000 for one Lucas, or $20,000 for a new Zoll or LifePak. Point-of-care is you can get them as cheap as $3,000. So between $3,000 and some of the higher end ones, maybe closer to $8,000 or $10,000. But that's really not that bad when you compare it to the Lucas, or the LifePak.
I think there's a move, if I'm not mistaken, that's going to be required equipment before it's over with anyway.
Mm-hmm. Yeah, and
I can see the benefits.
Well, and the next challenge,
literally,
I can see. Yeah, well, the next challenge is going to be education. Yeah,
and that's what we need to be. I think that's the other part of things that I like what they're doing with getting these Lucas devices out, is they're actually putting the training with it, because that's I think we threw them on a bunch of ambulances, but we didn't really train the people how to use them.
Right.
So it's not really their fault. Although if I got a piece of equipment and I don't know how to use it, it really is up to me to say, hey, I don't know how to use that.
Yeah. Yeah.
But education's always of utmost importance.
Absolutely.
Education saves lives.
Y'all looking at me like I'm supposed to talk.
Well, just
I know usually I do.
So
I really have
to have a good education system and like a training academy is just the benefits are just insurmountable. I think that if you had good training, you could really reach the stars.
Mm-hmm. You have a really really impressive vernacular there.
Yeah,
I thought you'd like that.
And I like that, reach for the stars. Yeah, I agree. Mm-hmm. I think I put that in a video I made the other day or something. Something went along with that. It was pretty good.
Okay.
Hey, real quick, shout out time. We talked to our Partners in Education, Bridge Valley CTC, who's going to come on the show at some point in time.
Oh, yeah.
That's actually what John is doing here today. He's teaching a paramedic class on behalf of Bridge Valley CTC here at Star Academy. So real quick to them, I'll put their logo up in here. We will have another medic class coming up through Bridge Valley in January.
Yes, starting.
So starting now is a really good time to start enrolling and get your paperwork and stuff done.
Absolutely.
Yeah.
So we got the paramedic class, which will be here at Star Academy, but we'll be in partnership with Bridge Valley, and we also, in the next couple months, we'll be getting ready to do a critical care transport, which will also be through that partnership as well.
Yeah, so many new things. So we just started the EMTM. And now we're also set up to do EMTM research, and now critical care, everything in AEMT.
Mm-hmm.
Yeah, so we just
Yeah,
got that one.
PHGLS, AMLS, all that. Yeah.
And all your research hours.
Mm-hmm.
We got you.
And it's coming up, so might want to give us a shout and start working on some of your research modules if you're out there and listening. I know our poor firefighters that are listening have been bored for most of this conversation, talking about drugs and cardiac stuff when all you want to do is cut people out of cars. But
Yeah.
I mean, we'll get to that one too. We'll get Chad,
Yeah.
some of those guys in here. It won't be all EMS all the time. So
My fire department guys are just amazing in the things that they do, and they do everything that we need to do to get off scene. So,
Yeah. I mean, we couldn't do what we're doing without them.
well, I got my start with the fire department. So,
Oh, yeah.
Yeah, so certified firefighter, and still responding to calls. So, of course, I let the younger guys take care of some of the heavy lifting. Now, so. but yeah, we love our firefighters. They're of the utmost importance to us, and our police officers are amazing as well.
Absolutely.
I love how well we all work together.
Yeah, somebody called me or messaged me today that they have a law enforcement officer that wants to come on the show.
That'd be awesome.
amazing.
Love to have
I'm trying to remember who it was. I'll find out. We'll get that scheduled. Also, Dr. Kyle. Somebody had talked to him.
Scott Hill. He had talked to Dr. Kyle,
Yeah.
and hopefully we'll, depending on his schedule, have him as a guest here very soon.
Yeah, Dr. Kyle would be great. I'd like to see our medical director.
Yeah, Dr. Miller.
Yeah,
That'd be
Dr.
awesome.
Miller.
Mm-hmm.
Come
Amazing.
in. That would be good. And I know John Fannin from Bridge Valley is going to come down and do a session, maybe a few with us.
Mm-hmm.
Yeah, maybe we should. One of our thoughts there is when we get Dr. Kyle over, have him talk about that medic timeout.
Oh, yeah.
Because I've been dealing
Oh,
with some
yeah.
football teams and schools that are not implementing that yet, and they just love it. It's a good program.
Well, I'm fairly certain, and I'm sure he'll correct me if I'm wrong, but the NFL has now adopted Dr. Kyle's medical timeout as part of their routine as well and their treatment on the field.
Oh, that's awesome.
Yeah,
Awesome.
big things
It's
are happening
it's
at
a
the
great
Kyle
program
group.
for
Yeah.
kids.
Yeah.
I like to see it expand past football to the other sports as well.
Oh, yeah. Yeah.
That's something to talk about one day soon.
Yeah, that may just be the start. We'll run it by him, see what he thinks.
All right, guys. Well, we are at 33 minutes. Closing remarks for our shock or no shock or whatever we're calling this session. Paramedic talk.
Paramedic Talk with Jon Cresong.
I like it. Ooh, that could be a show.
It
We
could
could
be
start doing more than one show a week.
There you go.
No, I think you've covered it very well,
Yeah,
John.
there's benefits and
Just like with
disadvantages to
anything.
both.
There's going to be two sides to every coin.
Just have to read the situation and know what is it. What's that saying? Know thyself.
Mm-hmm. Yeah.
So
And just to be clear, we're not advocating for
No,
one
one
or
or
the
the
other.
other.
We're just kind of having an open discussion about how things have changed over the past few years and some of the benefits and risk of doing each, really.
I had the big conversation, and I'll end my talk with this. Somebody was talking about IV size and everything. I said, you know what the best size IV is? And they said, what's that? I said, the one you get.
Oh, yeah.
Because if you don't have
Absolutely.
one. So
Coming
whatever,
from the man that I've seen doing EJ more than once.
Yeah. But I mean, if you are doing something a certain way and you're taking care of people, that's the way you need to do it.
Mm-hmm. Absolutely.
Agreed. I don't have a button for that. Oh, well.
We'll take
I'm
the
just gonna
buttons
skip
that
it.
way.
Okay, well, I guess that's about going to be it for us. A couple things I want to talk about. October the 3rd, again, Matthew, I'm pinning him down on the spot right now. He's going to give me some information to put out on our social media sites about this. Is it WVU? Mm-hmm. That is scheduled this thing. It's going to be here at the Academy October the 3rd. Do we have a time yet?
Yeah, it will be at 9 o'clock.
9 o'clock, and it's open to EMS, first responders. Mm-hmm. And it
free.
Is that like mental wellness.
Yeah, building resilience through mindfulness.
That's it.
Yes,
that's it. Right.
It's excellent, excellent class, and through thanks to our partners like Bridge Valley, we're able to offer it to the public for free.
Oh yeah, and we've already got 7 seats filled or more. I think it's more now.
I think I was close to 12 when I counted today.
Yeah, and we can have up to
35.
35. Okay, so give us a call, 304-207-0879 if you'd like to get in that class or get on our podcast or just suggest something you want to talk about, or even sign up for this EMT class that starts next week. The 18th and 19th are your orientation days, starting 5 p.m. till 10 p.m. You don't have to come both days. Just come one week, do your enrollment right there. So if you show up, sit down, we're going to have a good time. Let's see. Also, EMT minor class. I do have one scheduled for Monday. If you're interested in... Wow, I am stroking out, guys. Help me out.
Interested.
Is my face drooping a little bit?
I'm off the clock.
I can't say it either.
This is volunteer status only. I can choose not to. No, if you're interested in the EMTM class, you can also give us a call or send us an email at info.starwv@gmail.com. That's info.starwv@gmail.com. Or give us a call or visit www.staracademyonline.com. You can find all the information you want to find there. Don't forget to follow us on Facebook. I don't remember the Facebook exactly how it's worded for On Scene Podcast. I think it's one On Scene.
It is, yeah.
And then for Star Academy, it is Training WV. You can find it that way on Facebook. And I'll put a whole bunch of little stuff down here on the screen y'all can look at. I hear somebody in the hallway, and somebody got somebody.
Uh-huh.
That's okay. I'm not that interested. So I guess that's going to be it for us. John, got anything?
Nope, just keep moving forward.
Yep, that's what we do.
Thanks for hanging out. Appreciate you being here.
Glad to be here.
Hope you're here more often.
Yes.
And Matt? Okay, bye.
Ditto.
All right, you guys, drive safe.
Some content on this show could be considered offensive or graphic in nature. The views and opinions expressed on the On Scene podcast are solely those of the hosts and guests. They do not necessarily reflect the views of any affiliated organizations, sponsors, or third parties. The content is provided for informational and entertainment purposes only and should not be considered professional advice. On Scene Podcast, Star Academy, and their staff or affiliates are not responsible for the actions of any person who uses information from this show in their medical practice or decision-making. Listeners are encouraged to use their own discretion and conduct further research before making any decisions based on the information presented. In other words, don't be a dummy.
On Scene is sponsored by Star Academy.
Bruh.